Welcome to this talk. Now, a few days ago, we played a video clip from Mr. James Royle, who's a consultant surgeon in England, about what people are sometimes calling turbo cancers, a term without a precise medical definition, but it accurately conveys what is happening. These people are presenting with cancers rapidly at a later stage, and they're dying very quickly. But I don't want to talk about that today. I want to talk about the first part of this talk, which we haven't played yet. Now, this was at the Jackie Stone conference in Northern Ireland, and so called because Jackie Stone was a heroic physician who sadly, under intolerable external pressure, took her own life. So it was in memory of her. Just before we look at what Mr. Royle says, if you're feeling bad, whatever you do, stop what you're doing, go and tell someone. If someone comes and tells you that they're feeling bad, whatever you do, listen to what they're saying and take them at their word. Suicide is a terrible, terrible tragedy. But anyway, back to what Mr. Royle was saying. Now, he's talking about his clinical observations. Now, when a senior doctor talks about their clinical observations, we have to take this seriously. What's the point in having senior doctors if we ignore what they say? It just doesn't make any sense. We have to literally take them at their word and say, look, if this is your impression, then that's worth investigating. Now, he went back to 2020, 2021. He talked about the media generating a pandemic of fear, but he was able to carry on most of his cancer treatments, mostly. Now, he wondered where a lot of the surgical conditions had gone. So patients often get appendicitis, cholecystitis. Appendicitis is inflammation of the appendix, largely bacterial. Cholecystitis is inflammation in the gallbladder, largely bacterial, and these can be suppressed for a period of time with antibiotics, and maybe that's why many of these cases weren't presenting, but they tend to come back later on. The antibiotics tend only to put off the problem for a period of time, although that can be a very useful thing to do. Anyway, he talked about the harms done by lockdowns, which are self-obvious, that people were lacking vitamin D because they couldn't go outside. That reduced their immunity. And they were more prone to metabolic syndrome, all of which, of course, worsened the prognosis of COVID should they get it. And he then critiqued the vaccine policy as a one-size-fits-all policy. The whole point of medicine is it should be individualised. Care should be individualised to the patient. Each patient should be assessed, care planned, given and evaluated on an individualised basis. The one-size-fits-all thing is just an antithesis to any modern medical nursing thinking. We just shouldn't be doing that at all, and yet that's what largely... Well, that's what happened with the vaccines. Everyone get one size fits all. Genetic injection, experimental genetic injection, he mentions. Now, where it gets really interesting and really quite concerning is he's talking about new pathologies. These are disorders within the body that you hadn't been seeing before. So, for example, he saw a big increase in 2021 after the vaccine rollout of vaccine thrombosis, or venous thrombosis post-vaccination, I should say. Now, venous thrombosis, a thrombus is a blood clot where there shouldn't be one. So he was getting blood clots more than you would expect in the veins. And also on computerized tomography, CT scanning, he was seeing multiple pulmonary thrombosis in the pulmonary arteries. So he was actually seeing thrombus in the pulmonary arteries bilaterally on both sides. Now, normally, these would be called pulmonary emboli, and they normally come from things like deep venous thrombosis that goes through the heart, through the right side of the heart to the lungs, and lodges in the pulmonary arteries. But that's not what he was seeing. So he was seeing pulmonary thrombosis, not emboli. And the difference there is important because a thrombus is a blood clot in the vessels where there shouldn't be a blood clot. And if that moves, once that starts moving and drifting off in the venous flow, that becomes an emboli. It becomes an emboli when it moves. And it lodges in the pulmonary arteries because it's moved there. But that's not what he was seeing. He was seeing clots which apparently, reading between the lines, I think this is what he was saying, actually originated perhaps in the pulmonary arteries themselves, which is not what we would expect to see. So it was pulmonary thrombosis, not pulmonary emboli. Thrombosis meaning that the blood clots are started in the pulmonary arteries, not started in a leg vein or a lower vein and moved up to the lungs. Quite unusual, I must say. Not something I'm familiar with, pulmonary thrombosis. In fact, the mere reason that I've said several times in error pulmonary emboli just means it's so ingrained you always think of them as emboli, but these aren't. These seem to be a different pathology. They were not embolic. He was seeing abdominal venous clots in the portal vein, going from the gut to the liver, the superior mesenteric vein, draining part of the gut, and the splenic vein, draining the vein. Again, places you wouldn't normally expect to see clots. Classic risk factors were often not there. Of course, surgeons get to know what patients are likely to suffer from these complications. These classic things are not there, and these were often younger patients in the 30s, 40s, 50s, 60s. He saw ischemic bowel. Now, ischemic means inadequate blood supply. And if you've got an ischemic bowel, it can be remarkably painful because you get the buildup of lactic acid and that stimulates the pain receptors. It's a bit like cramp. So ischemic bowel he was seeing, very dangerous, of course. It can necrose and go gangrenous. He was seeing arterial clots. He was seeing the VITS, the vaccine-induced thrombocytopenic the vaccine-induced thrombosis with thrombocytopenia. In other words, the blood clots with the low platelets, which was recognised, but he was seeing that. Although whether that explained all the pathologies he was seeing is not clear. Probably not, I'm thinking. Spike protein, he was seeing in one or two patients or several patients, high amounts of spike protein antibody. And that could have caused some vascular ruptures, which is pretty frightening because if the vessels rupture, the blood just leaks out. He was seeing pancreatic necrosis. Necrosis means that the tissue is dead. So necrotic tissue is simply dead tissue. It's dead. If you get an elastic band, wrap it around your finger will lose its blood supply, go black and die. So, but necrosis of the pancreas is very serious. The organ at the top of the abdomen, especially after vaccine boosters. Spike protein antibodies he saw were high. Gangrene, which just means necrosis, dead tissue. And he was seeing cases of appendix cancer. Now, I have never heard of cancer of the appendix, and yet that's what histology had shown. So that was the first part of his talk. I'm going to play it now. So you decide if I'm interpreting his words correctly. And then he went on and talked about the turbo cancers as well. And I'll put the link to that video that we played last week. So both concerning. The thing that's perhaps more concerning about the turbo cancers is what the delay is after vaccine. So these effects he was seeing were relatively acute. How long are we going to carry on seeing increased incidence of unusual cancers in younger people is a question by definition, we don't yet know the answer to. Let's hope there's no increase. In fact, let's hope there's a decrease and that younger people don't get cancer. But unfortunately, it remains a concern. And we don't know definitively why. We just know that there's temporal correlations and plausible mechanisms. Let's listen to Mr. Royle now. I'll play the first half now up to the part where we got to last time. Be back in a minute.
Thank you for the introduction and for inviting me to share my observations and experience with you all today. My name is James Royle. I'm a general and colorectal surgeon working as a consultant in the northeast of England for the past 9 years. I believe the comments that I will make today are true to the best of my knowledge and belief. They are my own personal clinical observations and are not representative of my employer or the NHS. If I could first take us back to when a pandemic was declared, and then in March 2020, lockdowns announced. I was fortunate to be able to continue working, but driving to work on empty roads and then walking along empty hospital corridors were eerie and surreal experiences. To me, our hospital never felt overwhelmed. However, there was a great deal of psychological stress felt by many of my colleagues, mainly driven by the incessant media messaging. I agreed with a personal friend very early on. This was a pandemic of fear. I was not affected this way. I knew my personal risk was very low, and I was happy to catch COVID early if necessary and gain natural robust immunity. Although ICCU expanded its footprint from October 2020 in the so-called first wave, we were able to continue our urgent cancer pathways. All non-cancer planned surgery were cancelled, and we were only able to deliver telephone clinics. We diagnosed at least as many, if not more, colorectal cancers during this period, and we cancelled or deferred very few cases because in my unit over 95% of cases are performed by keyhole surgery, so patients routinely go back to the ward, not high dependency or intensive care. However, I was perturbed as to where all the general surgery emergencies had gone. The population was dutifully staying away and following the fear messaging to not overwhelm the hospitals and only present when critically ill. In retrospect, I think much of the appendicitis, inflamed gallbladders, and diverticulitis must have been managed in the community with antibiotic teleprescriptions. However, lockdown was a devastating failure, as I hope we all now recognise. At the time, I had been trying to speak up that it was not going to be effective and just cause harm, but was shouted down by even non-medical friends and family who were quickly lockdown experts. The detrimental impact to patients was obvious then. Being isolated and housebound, with incessant, terrifying media messaging generating huge anxiety and fear, leading to social and psychological stress, impairing immune function. The lack of fresh air, sunlight and exercise led to vitamin D deficiency, immunodeficiency, physiological deconditioning, and worsening of chronic disease and the metabolic syndrome, obesity, hypertension, insulin resistance, all risk factors for poor outcomes if diagnosed with as COVID-19. It was therefore no surprise to me that my elective cancer mortality rate went from 1 death in my first 5 years as a consultant to 6 mortalities within 30 days, 5 non-COVID, 3 of these sudden cardiac deaths. And then came what they said was our only way out of the pandemic, the coerced, so-called vaccines. Despite the promises that they were only for the so-called vulnerable, sure enough, it progressively became a one-size-fits-all. My red line, when I first spoke up, was to stop it for healthy children. I was skeptical from the start of the rollout of these experimental genetic injections and alert to potential problems. From around March 2021, I started noticing new patterns of disease suddenly frequently appearing that I'd never seen before in my patients. The first pattern was blood clotting, particularly venous thromboses. One of my secretaries asked me, "Why are all our patients coming back with clots?" I was encouraged someone else had noticed. CT scans were coming back, reporting multiple pulmonary thromboses bilaterally, both lungs, clots in the pulmonary arterial vasculature. These were not pulmonary emboli, as thromboses seen in the lung vessels are often called, because they did not usually result from embolization of a DVT, a clot in the leg, in these cases. They were occurring frequently as incidental findings on routine follow-up CT scans in my colorectal cancer follow-up patients. A new triad of spontaneous, unprovoked abdominal venous clots that I had not ever seen before, affecting the same 3 main vessels in multiple patients. Portal vein, from the gut to the liver, superior mesenteric vein, draining the small intestine, and the splenic vein. These patients, typically middle-aged, ranged 31 to 77 years, presented with a vague abdominal pain and no underlying pathology to cause the thromboses, no classical risk factors, e.g. absence of severe pancreatitis or advanced cancer, suddenly happening in multiple patients admitted under general surgery. Sudden increased incidence of ischemic bowel cases, usually uncommon. Many had no visible clots in their mesenteric arterial vessels on CT, as would normally be expected. This could possibly be due to microclotting in multiple small vessels or capillaries, or perhaps from thrombotic endocarditis, as Dr. Dean Patterson has suggested. These thrombotic cases I'd started testing for the VITS, vaccine-induced thrombotic thrombocytopenic syndrome, that had been defined in some patients after the AstraZeneca vaccine. However, I was seeing these cases after the mRNA, Pfizer and Moderna shots as well. 2 pregnant women presented in quick succession with catastrophic internal bleeding from what turned out to be inflammatory splenic artery pseudoaneurysms. One case I had to take to theatre for a laparotomy and splenectomy. The proposed pathophysiological mechanism of this almost unheard of event, as related to COVID-19 vaccine spike protein, was first described by the late Dr. Arne Burkhardt, a German pathologist. He demonstrated pathological specimens staining for vaccine-induced spike protein present in the vessel endothelium, leading to inflammation and damage to the vessel wall and spontaneous rupture. Spike protein has been found in many organs by Dr. Arne Burkhardt, work now replicated by others such as Dr. Ryan Cole. There is a new, significantly increased incidence of severe, often gangrenous pancreatitis in patients who don't look that ill on presentation, but their initial admission CT scan shows extensive pancreatic necrosis. This is areas of pancreas that have died. This is a new phenomenon. Post-vaccine boosters have observed what seem to be a lot of sudden deaths from necrotizing pancreatitis in elderly patients. One case was associated with more widespread ischemia affecting the stomach and small intestine. This patient had received a fourth booster no less than 2 weeks prior. Spike protein antibodies were over 2,500. The increased incidence of nasty inflammatory or infective emergency general surgery cases, such as gangrenous cholecystitis and gangrenous or perforated appendicitis, especially in middle-aged patients. This is unusual. Also, a notable increase in appendix cancers, considered rare, picked up incidentally on appendicitis specimens. Finally, I need to talk about cancer, particularly colorectal cancers.
Clearly, data needs to be collected from surgical units around the country. It needs to be pooled. It needs to be objectively analysed, and results need to be published. Pity that doesn't seem to have happened very much yet. The part where Mr. Royle talks about cancer, we did cover that last week. I'll put the link to that video on the end screen. For now, that's it. That's all I want to say for now. I'm going to share just one thing with you, though, because I kind of like sharing things. This was, I just went walking today on the hills, and I just had my phone with me, and I just took this picture. It's just thought it was interesting the way that the sort of beams of light come out here from both sides of the sun. Quite weird effect, just some aberration on the lens I would expect, but one almost seemed to be coming down sort of to ground level. It's nice to get out sometimes, renew your connection with the created order and put your place in the created order into some kind of perspective, perhaps. Anyway, enough from me. Just thought I'd share those with you. The link is to Mr. Royle's first video is on the screen, so do check it out. Equally concerning. And let's get some data collected nationally. We're not short of academics and data analysts. It seems a pity this is not being more thoroughly audited. But for now, thank you for watching.